right. So time is up. It's my pleasure to introduce Jason Perrin from Mannheim. He's going to talk about advantages of navigated robotics in a hybrid operating room setting.
Thank you. Thanks. That's the pointer. So, good morning, ladies and gentlemen. First off, I would like to thank the hosts of this course for giving me the opportunity to actually give this talk with such, you could say, prominence in spine surgeons and this excellence of faculty, and then to have me as a young colleague of one of those leapfroggers, you would call it, basically, to give this talk here. So, as Dr. Hedl already said, my name's Jason Perrin. I'm from Mannheim. This work? Okay, well, it's not this Jason, but the other Jason. So we're here to talk about the advantages of navigated passive robotics in hybrid OR setting. I'm very fortunate to have this setting in my clinic, and I think I'll just walk you through it. This is my disclosure. As we've heard all the talks between yesterday and today, we've seen the advantages of spinal navigation and that it's becoming more and more established. Not as established as one assume, as we saw in the previous talk with 11% of surgeons using navigation, but I think we're on the way of getting there, just like in cranial surgery. And just quickly to skip through the common technologies, we've seen all of these, the 2D fluoroscopy, 3D fluoroscopy or 3D vision, and then interoperative CT and mobile CTs. Well, in our setup in Mannheim, we have a bit of a unique setup. We have a floor-mounted robotic 3D flat panel CT. Basically, it's a cone CT, cone beam CT, and a ceiling-mounted curve system for the navigation. And this is what it looks like in real life, not to just show catalog images. This is basically the two large view displays, the control unit and the 3D flat panel CT. To put it short, it's an angiography system. And so we can use this for our spinal surgery and in conjunct with the navigational system. So, and in addition to this, as we've seen in the exhibition downstairs and as we seen in many of the talks, we have robotic systems on the uprise, semi-robotic systems that are increasing rapidly. The technology is developing rapidly. And I like the slide that Dr. Hedl showed, where we have to fuse these technologies. We have the imaging, and we have the robotics, the reality, the virtual reality, the navigation. We have to fuse these technologies and suss out a workflow where these technologies intertwine really well. So yeah, I would like to then demonstrate this workflow of the fusion of these technologies that we've established in our department. We have a maximum range or maximum flexibility with a large range of motion with intertwining these two systems, so it makes it quite easy to integrate. And this is my personal evolution. Like I was saying, a lot of the colleagues here and the pre-talkers have years and years or decades of experience. My first navigated case on my own was October 2016, so it's just about 3 years now. And this is my evolution from starting with Yamshidis and alls, going over to the navigated drill guide, and then being fortunate because my boss ticked off all the boxes when he ordered new technology to have this passive robotic arm. And he just said, use it, make sure it works. So this is the positioning using in the hybrid OR, the standard prone positioning for radiographic markup. And I think we'll just go through the workflow because it demonstrates the abilities of the system better that way. And this is then the interoperative collision check that we perform to make sure there's the positioning of the patient doesn't endanger the system crashing into the table of the patient. You saw the rail there. That's where we're going to mount the robot or the passive robotic arm. The special draping technique to make sure everything stays sterile, and we could use it for fluoroscopy and for our CT scan. And then, as we've seen, we have the incision, the reference array. I think we can just quickly skip through this. And then we have our interoperative image that we take where we're standing outside of the OR to eliminate radiation exposure. Again, I think this is a large subject that's already been addressed quite frequently. So we control this with the foot pedal. It takes about 5 seconds. Then here, don't be irritated. I changed my gloves and everything. I was just helping the smaller scrub nurse to mount this robotic arm to the table. And when we further drape the system, all this takes about 2 minutes. And then I kind of fling my gloves away. and then continue with the surgery there. And now we can, when we've made our incision and we can just align up the system, it's a lock and release system. Neurosurgeons or a lot of surgeons that use microsurgery or microscopes will know this lock and release mechanism from using our microscopes in the OR on a daily routine. So that's why it's passive robotic. It's mechatronic arm, you could say. And then you can fine adjust once you have contact to the bone, where you can pivot and move it and make sure that you have the optimal trajectory that you need. And then furthermore, you can, if necessary, like in the thoracic spine, you have the the ribs coming up, or the transverse process, you can wedge the drill guide into the bone to make sure it doesn't slip. And then this is a slide I like. I can optimize things if I have to, and seldomly, luckily enough, and I don't have to hold on to anything. So I can change the screw size and whatever I need to do, because all the products and the implants in Germany are sterilely packed. I don't have a tray of screws anymore, so I have to make sure I pre-plan in real time, if possible, in the OR, and then order all the screws and the screw size that I need. And this kind of eliminates this factor where somebody holds a drill guide and then you just kind of optimize things. And I always drape my monitor and use it myself to increase work efficiency, because we also have a problem with lack of staff. I don't know if it's like that out here, but in Germany, I think that's a large issue at the moment. So this kind of eliminates that factor. I like to compare it to this. I can concentrate on something without endangering losing a trajectory or ruining my surgery in that position. So we kind of evolved to this kind of step now. So if I continue, then we'll just go through the workflow here again. We drill through the navigated drill guide. My resident kind of bored, turned into a one-man show, but I let him do the other side, so it's not like that. This is a cervical case, and then we place the K-wire. I know we've been talking about eliminating K-wires. We're working, or we will hope that this will come in the future, that we have a drill tap screw system where we don't need a K-wire and just place it through a tubular system. So we can skip through this, finally a bit of action. And then we place our screws in a navigated fashion. So we can just set the robot aside. It doesn't take up too much space. It's not space consuming, and it's integrated into our workflow without hindering us. We don't have to move it around, have a scrub nurse or anything, push some machinery around, and then I can just park it up if I want to do an interoperative scan to control my implants, and then it remains fixed to the patient table for the scan. It doesn't matter in what position. We have the same for the cervical spine. Sorry, I didn't turn off the sound here. And then just to quickly skip through, I think my time is running out, and for the thoracic spine as well. So we kind of evaluate the trajectories and compare the alignments of the plan, the pre-plan, the place screw, the navigated screw, the postoperative images, just to kind of evaluate that scientifically. So just to summarize, the advantages of this system, in my opinion, my experience, like I said, I was fortunate to have this system. I think I was, luckily enough, one of the first in the world to have it, and I've done about 70 cases with it. So I'll get to that at the end of the slides. Is to find out what's nice to have and what is a need to have. And I think this is a transition that has to be made, and you can only know this by using it. And I mean, we can all say and speak out against these technologies, but if we don't have it, then it's just not virtual reality, but it's just assuming things. But if we have it there and we use it, then we can actually evaluate and say what is advantageous and what is not advantageous about it. So we have a comfortable work economic due to its small dimension. It takes up only a little bit of OR space. This is me standing next to the scrub nurse. I don't know why she needed to step there, maybe to degrade me, but she's quite tall. Anyway, then we have good work economics for single surgeon surgery. This is like when we're doing cervical pedicle screws, somebody holds the drill guide, someone drills to make sure we keep the trajectory and look at the monitor, etc. And there we have it, kind of nullifying that factor. And it has enough rigidity and sturdiness needed. Although it's small dimensioned, it increases safety for placement of high-risk screws. I think we've been through all that. We've seen the literature that pediatric cases, cervical cases, we had we was very beneficial of being able to do a pediatric case with Professor Harms, just like 15 miles away from us. He still operates, I think 75 years old, and it integrates very well with our navigation and our image system. So it's cost effective as well, because this system is not that expensive. and it integrates with our navigational system. We can use it for spinal, for cranial surgery, for biopsies, and ENT use it for endoscopy as well, maybe for thoracoscopy surgery. So, and then just quickly to go through the advantages of our robotic interoperative image system. It's fast, it's an automatic registration, it has CT-like quality, up to 6 levels, depending. You know, if Shaquille O'Neal, maybe 2 levels, Danny DeVito, maybe 10 levels. So obviously, depending on the patient's anatomy. And it's a fluoroscopy, a cone beam CT, and an angiography system in one. So we don't need, like the aero CT is excellent, no doubt, but you'll always need an extra fluoroscopy device if you're doing lateral approaches, as we mentioned before. This, we have it all in one. It has a position memory. And my favorite add-on is we don't need no extra staff. Like I was saying, lack of staff, lack of technicians, and positioning a C-arm can be, as you could say, quite challenging. I don't know if this is going to work. It should work. Sorry. Yeah, that's a shame. Anyway, positioning a C-arm is quite challenging when you see trying to park a car and you're taking about 15 moves to get this car parked in the right position for your fluoroscopy. And it's the same thing. It has position memory. So disadvantages, cost obviously is one thing, but you can nullify that by using it in different disciplines, in a hybrid OR, thoracic surgery, cardio surgery, etc. And the learning curve, I think, like I said, my first case, October 2016, using this 3D flat panel CT, I think we've done about 600 cases. And the learning curve is there. It's quick, it's efficient. The time add-on is about 12 minutes from incision to having our navigated data set. So I don't think that time factor is such an issue. So on a future outlook, the OR real estate is obviously an issue, but there's devices there, cone beam CT, as a mobile robotic device that can be driven around from OR to OR. I think the future is there. And it's a modular system where we can add on a fully robotic unit because it's passive robotic. And I think that's a speed issue. If you have a fully robotic system, it takes time to go from planned trajectory to trajectory. The robotic has to move itself. If I can move it myself with a lock and release system, I'm quicker than a robot, and then let it go and it can align to my pre-planned trajectory, and that saves your time there, and you still have the accuracy of a fully robotic system. But you kind of faster when you move the main unit itself. So that's to conclude. And like I said, we need a rapid transition from nice to have to need to have. And I think that's the way to go to test these technologies. And that's where we have to work with the industry to tailor it to our surgical needs as clinicians. Thank you very much.
Thank you. I think it was really nice to see the workflow, you know, step by step, how you do it. And we may disagree on some of the particular steps, but I think it's really nice to see, you know, how you do that. And I'm a little worried about the K-wires, but I know that's a transient problem, challenge.
Yeah.
But it was really nice. Any comments, questions, or does anybody use the Zigo? It's a Zigo, right? No,
Yeah.
Zigo.
Yeah.
Does anybody else use that for navigation? We have a system here, and we use it. We've used it a few times for spinal navigation. But you need the room. The key is that the room is set up in a certain way.
Exactly.
Yeah.
Yeah. So no questions. It's more of a demonstrational presentation.
Raj has a question here.
That was a really nice talk. I know in residency I actually use the O-arm quite a bit, and here we use the BrainLab Aero, which, you know, obviously are their mobile units. And in your opinion, with doing C1, C2, for instance, I know a lot of times we do cranial reference arrays when they're in the Mayfield. Do you feel like that's more accurate in your workflow doing? Because I heard you talking about cervical pedicle screws as well, which is not really done commonly, right? Mm-hmm. So the question is do you think that the cervical navigation, especially with how hypermobile the cervical spine can be, that this is more accurate than a traditional, you know, O-arm or, you know, like an Aero CT?
I would have to compare the data, but I wouldn't say it's more or less accurate. I think doing cervical pedicle screws comes down to where do I plan down my reference array, and plus you also have the opportunity of surface matching where you can match level for level. I can use the reference array, I can use the automatic registration, or I can use the surface referencing. And I think if you use for cervical pedicle screws, the most accurate way would be surface matching because you're matching level for level, and that kind of nullifies the mobility of the cervical spine. But otherwise, I would place it on C2 or C7, TH1, and I've never had an issue so far. Touch wood, yeah. So.
Maybe we'll maybe Robert Eastlack in the back. Sorry. What are your thoughts about the different types of imaging technologies? You know, the O-arm, intraoperative CT, the Zigo here. Do you have any strong opinions, one or the other?
I wouldn't say strong opinions, but they're the accommodation for the needs of whatever facility is getting them is paramount. If you have a small hospital, you tend to have to need instruments like this that serve different masters. If you have a place that can accommodate 3 nav systems, you can have all the bells and whistles for each service. But I think a lot of community hospitals, outlying hospitals, need to have equipment that can serve different services needs, and they're going to be a little more concerned about the capital cost of each of these tools. So to the robot point, you know, if you have a lower cost alternative that provides robotic assistance, I think there's going to be a valuable place for that in certain hands. So in the end, all of these things will get cheaper with time, just as all new technology does. But as we start introducing them, we'll have to be considering those things.
Now, my concern when I see these arms is always the skiving, right? I mean, the one meaning you're slipping off. You're trying to drill a hole into the pedicle, but then the surface is very corticated or is oblique or whatever, and you're slipping off, and you can't drill. I mean, the nice thing with freehand navigation is that you can kind of compensate. You first of all, you feel when you're slipping off, and then if you're slipping off, you can kind of compensate one way or the other, and then redirect to a certain extent. The challenge I have with robotic surgery or with arms is that you can't really, you know, it takes that manual control away. Do you have any thoughts about that?
Yeah, I do. With the first cases, that's exactly what I experienced, especially in the thoracic spine or thoracic spine, because of the angulation. That's where I showed the slide where I kind of wedge it. That was my first experience. Okay, common sense. I got to take the teeth of the drill guide and wedge it into the bone, and it eliminated that factor. And the other thing is, when I showed the slide with the Tesla, I can watch the monitor while I'm drilling, and I don't have to look back and forward. And if I see a slip, I can stop and then micro adjust and rearrange, and it's okay. But it hasn't been so much of an issue, at least so far, of it slipping and scafing somewhere into dangerous territories. So.
Is Robert still here, Isaacs? No, I was going to ask him a question. Yeah.
Responsiveness too. So these new systems are accommodating some of those issues of skiving and adjusting in a much savvier way than we used to see them. So I think
that's a good point. The automatic module, I've tested it extensively. That also has a visual feedback if it slips from its planned trajectory, so you know in real time, okay, something's off. And you have a color visual feedback, so it kind of senses it.
Which automated?
As in the passive arm with the automatic robot module that I showed at the end. Oh. That kind of interchanges and adds on with the automatic alignment, and that reacts to slippage.
That's the next generation that's going to turn it into a real robot?
Yeah, you add it on. So you passively move it into range of the planned trajectory, let it go, and then it aligns itself automatically in a small field. And then you, especially like for cranial surgery, for biopsies, it's really, really excellent.
All right. Well, thank you. Any other questions? Or